a very warm welcome to all my learners on Dr. Reena's Physiology, Conceptual and Integrated. And today we are going to deal with one of the very important topic. Yes, it's ECG, right? So it is not very easy to compile ECG in one lecture. So what we will do today will be mainly understanding the concepts of the various ECG leads, right? But before that, I please tell you to subscribe, like and comment the channel so that everybody can be accessible with free physiology. And I provide my notes on my Telegram group, that is Physiology Synapse to Success, and here is the link of the channel also. So I please request that if you've not subscribed, do subscribe and please share a lot. So this is your mentor Dr. Reena Kaur, and today I'm going to pass you through a case-based learning. The basic concept of ECG will be taken in this lecture. But you know that nowadays, because we get the questions in the form of a clinical base, so I think one question you must always be aware of. So a very typical clinical based question, which is an SAQ to you. A 57-year-old man which comes to the emergency department with complaints of chest pain. Very interestingly, this is the biggest clue that is given to you, that it is radiating to the left arm and jaw. This is a type of a referred pain, which is because of the common dermatomal origin, embryonic origin. And he feels very anxious, diaphoretic. What is diaphoretic? Highly perspiring, बहुत सारी sweating हो रही है, and there is shortness of breath. History with type 2 diabetes and hyperlipidemia, that is raised blood cholesterol lipid level. On examination, he is in distress, he is anxious, and therefore ECG recording has been done, which shows an evidence of acute myocardial infarction in the inferior leads. And the physician suspects left artery, anterior descending artery is involved. So this is the typical question or a clinical case. Sometimes you may be given that it is a clinical history of myocardial infarction. Sometimes you may not be given and you may ask to diagnose the condition. So remember, chest pain radiating to the left arm is the biggest clue. Now, what could be the proposed questions? For example, what would the ST segment in this ECG look like? On which lead will you see the ST segment changes? What represents the T wave? Or I can add like what is the diagnosis of this condition, but however I've given it, but I can ask if suppose if I'm in a mood of not giving you the diagnosis, or I could say how is the management of the patient, or what is the physiological basis of management of this patient, that is what is expected at the level of first prof, right? So I've given you the answers because today the basic concepts is to teach you the ECG leads, right? So for example, this is a case of a chest pain, ECG evidence, myocard injury, which is showing ST segment elevation in the inferior leads. Which are the inferior leads? They are lead 2, 3 and AVF. T wave, we know that it represents ventricle repolarization, and ST segment appearance here will be the elevation of the ST segment, right? So this is a kind of a question and answer form which you are going to attend, or you're going to give when it is asked in this manner. Now, what is ECG? So remember, ECG is the electrical activity of the heart. It is the graphical recording of the electrical activity of the heart. So it is actually representing the algebraic sum of the action potentials of individual cardiac muscle fibers. ECG is being recorded with the machine, that is electrocardiograph. The method is electrocardiography. So gram जब हमने बोला, that is the graphical record, the procedure is electrocardiography and the instrument is electrocardiograph. Now, what is the basis? It was first discovered, this was discovered by William Enthovin. So William Enthovin, who has received a Nobel Prize in Physiology or Medicine in 1924, he is the discoverer of this, which is one of the most valuable non-invasive method of determining the condition of the heart. So understand that what is body? A body actually behaves as a volume conductor. That means the body, it is made up of body fluids, and there are lots of electrolytes. So what happens, that electrical activity which is generated in the heart is quite sufficiently bigger as compared to the other body tissues, and it can be easily conducted to the body tissues, and you can pick them up when you place suitable electrodes on the body surface. So body being a volume conductor, it is easy or it is feasible to measure the electrical activity of the heart, which is ECG. जो रिकॉर्डिंग हम फ्रॉग्स में करते हैं और आपको ग्राफ दिखाते हैं, दैट इज रिकॉर्डिंग ऑफ द मैकेनिकल एक्टिविटी ऑफ द हार्ट. रिमेंबर, जो आप एम्फीबियन प्रैक्टिकल्स में ग्राफ देखते हो, दैट इज रिकॉर्डिंग ऑफ द मैकेनिकल एक्टिविटी ऑफ द फ्रॉग्स हार्ट, वेयर यू गेट द सिस्टोल एंड डायस्टोल, एंड दिस इज व्हाट इज इलेक्ट्रिकल एक्टिविटी. ओके, नाउ what is actually the use of this ECG. So an ECG is going to give you an idea about heart rate, an idea about cardiac rhythm, cardiac hypertrophy, myocardial ischemia or infarction, conduction disturbances, or the electrolyte changes. So if you get a 2 marks BAQ on the uses of ECG, you can put forth these ones. Remember, ECG cannot give any information regarding your cardiac output or your blood pressure, right? So these aspects cannot be determined by ECG, but it is very, very important for the above or the forementioned ones. Now, before you proceed on to ECG, it is very important that you must always study that what are the pacemakers of the heart. Then how is the action potential? You know that the ventricular action potential is a plateau potential, and the SA node potential, which is supposed to be a slow response, and where you get the pacemaker potential. So the pacemaker of the heart is the SA node. Why it is pacemaker? Because it is able to generate the impulses at the fastest rate, and it is called as a override suppression. That means SA node does not allow any other tissue or any other part of the conducting tissue to generate impulses, right? इसके पहले AV node will try to generate its impulse, SA node will provide its own. So unless and until there is a problem with SA node, there is always going to be the pacemaker as the SA node. Always remember about the AV nodal delay. This is very important, AV nodal delay, which is about 0.1 second, which comes as an MCQ also. And you know the reason, that there is small diameter of the AV nodal fibers. Okay, the number of gap junctions are less, and the electrical activity there is very slow. And this AV nodal delay enables or ensures that the atria, they empty completely into the ventricles before the ventricles start contracting. So that is the significance of the AV nodal delay. And once the fibers, they come here through the bundle of His into the Purkinje fibers, simultaneously there is going to be the depolarization of both the ventricles. Now a very brief description about the spread of the cardiac impulse. This itself can be a short note to you, so I've taken this over here. Now when you consider the spread of the cardiac impulse, you know that in the heart the depolarization begins from the SA node, which is the pacemaker of the heart. From the SA node through the various internodal pathways, there will be depolarization of the AV node. The AV node will show an AV nodal delay, and then it will proceed through the bundle of His, reaching the middle of the interventricular septum. Now this is very interesting, that the left wall of the interventricular septum is the first to be depolarized. So this also becomes my MCQ. The left wall of the interventricular septum is the first to be depolarized. Now this electrical activity, it will cross like this, okay, from left to right. So the electrical activity is going to cross from left to right side of the interventricular septum. So suppose this is the interventricular septum, the electrical activity first depolarize the left side, it will cross from the left to the right. This is called as your septal depolarization, right? It is called as the septal depolarization. After the septal depolarization, the wave is going to travel towards the apex. So it is now going to travel towards the apex and then return back upwards towards the base of the heart. Okay? So interventricular septum crossing from left to right, going towards the apex and moving up towards the base. And this is very important, that the last part of the heart to be depolarized is the posterobasal portion of the ventricle. Posterobasal portion of the left ventricle, then the pulmonary conus. The pulmonary conus and the uppermost part of the interventricular septum. The uppermost part of interventricular septum. This also comes as MCQ and therefore I have highlighted this as well. Now something very interesting, that in the heart, you know that the depolarization is from inside to outside. That is, it is from the endocardium to the epicardium and from the base to apex, right? So I repeat, depolarization is from the base to the apex and andar se bahar from the endocardium to the epicardium, whereas repolarization is not in the same direction. Normally what happens, जहाँ से depolarization start होता है वहीं पर repolarization होना चाहिए. Heart में this is not possible, because I'll tell you the reason. Repolarization is from the epicardium to the endocardium, that is from the apex to the base. What is the reason now? You know that as depolarization is an active process, so repolarization is also an active process which requires energy. You have to re-establish the RMP. During systole, after depolarization, there will be systole. There is forceful contraction of the ventricle, especially the subendocardial part, okay, the subendocardial part of the ventricles. Wahan par the blood vessels, they get compressed. So because the blood vessels, they get compressed, they are not receiving sufficient blood supply to initiate the repolarization. Therefore, in the intact heart, when the heart is within the body, it is intact. The depolarization and the repolarization, they are in different directions, right? So here comes the question then, who is the first to be repolarized? We have seen the last to be depolarized, the subendocardial portion of the left ventricle, the pulmonary conus, and the first to be repolarized are the epicardial surface of the apex, the epicardial surface of the apex, whose blood supply is least affected during contraction. मतलब जो part का blood supply सबसे कम affect हो रहा है, that is the part which is going to repolarize first. So these 2 to 3 slides are very, very important to understand the further basics of the ECG leads and the waves. And this also comes as a short note, just as the spread of the cardiac impulse or conductivity. Now, what is the concept of this dipole? Now, if you look into the heart, you know that in heart what will happen is that the depolarization wave, it will travel in a particular direction in the heart. Okay, it will travel in a particular direction in the heart. So the part that is getting depolarized, what will happen to the part that is getting depolarized? The outer will become negative and the inner will become positive. So this part of the heart is getting depolarized, and there is adjacent or the neighboring part which is yet to be depolarized. So it will be positive outside and negative inside. So there is a demarcation, or there is a line that is separating this depolarized part from the polarized part. That is what is called as the activation front. This line is called as the activation front, right? So jab the wave of depolarization is traveling, I mean the electrical activity is traveling, it will travel from one point to another. So the one part will get depolarized and the adjacent part is yet to be depolarized. So what are you creating? You are creating this dipole, isn't it? There are two opposite poles, one is negative and one is positive. So this is what is, you are creating a dipole. This dipole will have a particular direction and a particular length. Suppose this is the length. So this length is giving an magnitude. Okay, this length is giving magnitude, and this arrowhead will provide us the direction, and the direction will always be from negative to positive, right? So the heart is behaving like a dipole, and at a particular instant, you take a particular moment, different dipoles will be there, because there is simultaneously electrical activity which is spreading throughout the heart, है ना? So every time the heart is creating a dipole, so that is what is the vector word we use. Okay, it is expressed as the dipole vector. So the summated effect, okay, the summated effect is what we called as the vector. So when we speak of vector, the summated electrical poles or the dipoles which are generated will be having a vector. This vector has got particular length, which is the magnitude, and the direction, which is always from negative to positive side, right? Now in ECG, remember something very basic, that when the current flows towards the positive pole, you are going to get a positive deflection. When the current flows towards the negative pole, you are going to get a negative deflection. But when the current is flowing perpendicular to the lead, okay, perpendicular, you will get this biphasic response, right? Now let's add on to this vectors. So you can see this is the beautiful diagram which is showing us the various vectors, right? Now you know that when you study the ECG, it is P, Q, 1 minute. You've got a P, a Q, R, S and a T wave. Now how are we generating these waves? So you will understand it very, very nicely now. See, let's look on to the various vectors which are produced when the electrical activity spreads through the heart. So this is P wave, what we say, or this is the vector of the atrial depolarization. So this is the vector of the atrial depolarization. Now the vector of the atrial depolarization is small because the atrial mass is small, isn't it? Because atria is very small as compared to the ventricles. Therefore the vector is small, the magnitude is small, and it is directed down and towards the left. Down and towards the left. The ventricles are made up of 4 vectors. So this is the first vector. Can you see this crossing from left to right? The one, this one which is showing septal depolarization. I told you there will be septal depolarization crossing from the left to the right. The second vector, which is directed downwards, which tells us that the cardiac impulse is moving downwards towards the apex. The third vector is the strongest vector. The strongest vector because there is the point where there is simultaneous depolarization of the ventricles, the right and the left, which produces the biggest or the strongest vector. And finally, the vector 4, which is moving upwards over here. ये क्या होता है? This is when the impulses are passing up and towards the basal portion of the heart. So this atrial depolarization is resulting in the P wave. This septal depolarization 1 is resulting in the Q wave. This strongest vector, which is going to be the summated vector of the ventricular depolarization, is your R wave. And this fourth vector, which is showing that the impulses are moving back upwards towards the base, is your S wave. And finally, there will be atrial repolarization, which will produce, ventricular repolarization, which will be producing the T wave. So this is very, very interesting that whatever vectors are created, the electrical activity itself is telling us that what is the cause of the ECG waves. So you need not mug it up once you've understood it. So I've given you the notes also, you can go through it. See the vector of the atrium directed downwards and towards the left, and the 4 vectors. The first vector septal depolarization, the second vector moving down towards the apex, the third vector, the strongest vector, depolarization of the left ventricle down and towards the left, and the fourth vector, depolarization of the base, upper portion, uppermost last portion. So the resultant of all the 4 vectors of the ventricles is called as the mean electrical axis of the heart, which is downwards and towards the left, making an angle of 59 degrees with horizontal, that is the main electrical axis of the heart. So for time being, this much is quite sufficient, right? Because how to deal with the axis, how to calculate with the axis will be a step ahead after you understand the leads. Now, when we consider ECG, we always speak of leads. So what is a lead? The first thing which must be nicely understood to me कि lead क्या होता है. Remember, lead is nothing but it is actually a pair of electrode. And ECG may, suppose this is two electrode, 1 and 2, and this is forming a lead. We have to take the potential difference between the two. For example, this is 6, this is 4, so difference will be 2. That what we are taking, and therefore we need a pair of leads. So sometimes both the leads, both the electrodes will be active, some of time one will be active, another will be inactive, and so on. Now we use 12 leads in ECG, right? We have got the Goldberger's standard bipolar limb leads. These are leads 1, 2, 3. We have got 3 augmented unipolar limb leads. A stands for augmented AVR, AVL, AVF. AVR is for the right arm, AVL is for the left arm, and AVF is for the left foot or the left leg. We have got 6 chest leads unipolar, V1 to V6. Something very important to be noted down is that all the leads are unipolar except the bipolar leads. So जो ये bipolar limb leads है, मतलब lead 1, 2, 3, सिर्फ यही जो leads है ना, these are bipolar, rest all of them are unipolar. So this is a very easy and a beautiful diagram for you to remember that there is a color coding. Ride your green bike, ऐसे हम याद रख सकते हैं. Ride your green bike. So right arm red, left arm, left leg green, left arm yellow, left leg green, and right leg you use an extra for earthing. Okay, that is which you use. So these are the bipolar limb leads. Now, how are we getting this bipolar limb leads and what is the fundamental of this leads? So what happens is, as I told you, that what we do in these leads, we have to actually find out the difference or the potentials between the two. So in the case of the bipolar, we are using 2 leads. Both of the 2 leads are active, where one of them is going to be positive and the other one is going to be negative. Very simple. So bipolar में हम 2 leads use कर रहे हैं, दोनों ही active है. One positive होगा, second negative होगा. And we are getting what is lead 1, lead 2 and lead 3. Lead 1 में the positive electrode is left arm, negative right arm. Lead 2 left leg, right arm, and lead 3 is our left leg and left arm, right? This have to be known to you, because without knowing this you cannot move ahead with your laws and with the mathematics which you have to understand, right? So एक बात और ध्यान रखना, हम लोग ये left arm को we can also write, you know, when it is left arm VL, right arm VR, and left foot as VF, or the left leg VF. So I can write this lead 1 as LA minus RA, but I will also write it as VL minus VR. So the moment you come VL minus VR, remember it is left arm and it is right arm. Now this was basically done as you have written also. So lead 1, lead 2 and lead 3. Right? Because they can be designated as VL, VR, VF. So I've tried to make it very, very simple so that there is less confusion and more understanding. Now, this all was done by your Enthovens, for which he got the Nobel Prize. So this is nothing but the Enthovens triangle. So Enthoven, he made an arbitrary triangle taking the source of current in the center. So here the source of current is the heart, and you've taken 3 imaginary points, the acromion process, right and left, and the pubic symphysis. So this becomes your lead 1 between right arm and left arm, the lead 2 between right arm and left leg, and the lead 3 between left arm and left leg. Please be very careful regarding the positive and the negative terminals. You cannot change them, because even if you by mistake change them, you're going to make a very gross mistake, rather a blunder. So ऐसा बिल्कुल भी मत करना, बिल्कुल अच्छे से ड्रॉ करके इसको आप करेंगे. Don't mug up, don't mug up. This is the biggest suggestion I will give you. Understand, draw it. Now, now we've understood that what is the lead 1, what is lead 2 and lead 3. Now it is quite apparent that the voltages in the lead 1, lead 2 and lead 3 would have been 0. ठीक है, मतलब lead 1, lead 2 और lead 3 अगर हम तीनों को ऐड करें तो ये 0 बन जाता. कब? If in the lead 2 the positive electrode was placed on the right arm and the negative electrode was placed in the left foot. हमने क्या किया हुआ है लीड 2 में? हमारा पॉजिटिव टर्मिनल लेफ्ट फुट है और नेगेटिव टर्मिनल राइट आर्म है. इसको अगर हम इंटरचेंज कर देते, राइट, इसको अगर हम इंटरचेंज कर देते, मतलब पॉजिटिव इलेक्ट्रोड को अगर हम राइट आर्म में प्लेस कर दें और नेगेटिव इलेक्ट्रोड को अगर हम लेफ्ट फुट में प्लेस कर दें, मतलब जो लीड 2 है उसको हम VR माइनस VF कर दें rather than VF माइनस VR, तो जो ये सम ऑफ पोटेंशियल्स है 1 2 3 ये बन जाता 0. Now Enthuven understood this and he deliberately reversed the polarity of the lead 2. So Enthuven determined this, he examined कि ऐसा होगा, इसीलिए उसने क्या किया, he deliberately reversed the polarity of the lead 2 so that सारे ही तीनों bipolar limb leads में the waves are going to be upright. So this is very important part to be understood, that Enthuven reversed the polarity of lead 2. ठीक है, मतलब नेगेटिव और पॉजिटिव टर्मिनल को सोच समझ कर रखा गया है, सो दैट द सम ऑफ द पोटेंशियल्स ऑफ 1 2 3 दे डू नॉट बिकम 0. सो this is the Enthuven's law. What is the Enthuven's law? This comes as a 2 marks MCQ. This comes as also MCQ plus a 2 marks BAQ. Lead 1 plus 2 plus 3 is 0, or you can say that if you know the potentials of any two, for example 1 and 3, the 2 can be algebraically determined. So this is the Enthuven's law. So what did we do in bipolar? We took we took two electrodes. Both of them are active, where one is active and one is positive and the other is negative. Now we come to the unipolar limb leads. अभी हम क्या बोल रहे हैं, that what is lead? It is a pair of electrode and हमें क्या चाहिए? We want the potential difference. उसके लिए हमें 2 electrodes चाहिए, है ना? जैसे हमने बाइपोलर में क्या किया, एक तो नेगेटिव ले लिया और एक पॉजिटिव ले लिया, लेकिन यूनिपोलर में व्हाट इज द प्रॉब्लम? इट इज ओनली वन active electrode. There is only one active electrode which is called as the exploring electrode. अभी दूसरा वाला जो इलेक्ट्रोड है उसका हम क्या करेंगे? How we going to generate that electrode? तो यूनिपोलर में सपोज इफ इट इज द चेस्ट V1, it is going to pick up the electrical activity of only V1. Suppose the electrical activity of V1 is 5 millivolts. It has to pick up that electrical activity. But now लीड इज अ पेयर ऑफ इलेक्ट्रोड, सो ये दूसरा वाला इलेक्ट्रोड हम कहाँ से लेकर आएंगे? सो वो दूसरा वाला इलेक्ट्रोड इज नथिंग बट इट इज कॉल्ड एज द इनडिफरेंट इलेक्ट्रोड विच विल ऑलवेज हैव अ जीरो पोटेंशियल. दैट मीन्स इन द केस ऑफ यूनिपोलर लिम्ब लीड, सपोज V1, it will be V1 minus indifferent electrode, and indifferent electrode का potential is always 0. So 5 minus 0, that means 5. That means you are picking up the electrical activity of only that particular unipolar lead. But again, उसको generate कैसे करेंगे? How are we going to create that indifferent electrode? That is very interesting. So let's see. So look on now. So that indifferent electrode is also called as the Wilson's central terminal. Now when you draw this equilateral triangle which is given by Enthuven, and you take the potentials at these 3 points and you see that these potentials are zero according to the Kirchhoff's law. But practically you will not get it zero. What is the reason? The reason is this conceived triangle is not exactly equilateral. So even if you look it is not exactly equilateral. And second, the source of current like heart is not exactly in the center. It is not exactly in the center. So it is not ideally following the law of zero. So what did we do is to tide over this problem. Okay, to tide over this problem, 3 resistance of 5000 ohms each. I repeat, 3 resistance of 5000 ohm each are connected, one to each electrode, and which is placed at the apical points. So हमने क्या किया? Each of them was connected with a very high resistance of 5000 ohms. और ये तीनों को हमने एक पॉइंट पर, एक इलेक्ट्रोड पर कनेक्ट कर दिया. That electrode became the Wilson's terminal, which was always having a zero potential, and this became your indifferent electrode. So how did you create an indifferent electrode? By connecting each of the terminals, right arm, left arm and left foot, with 5000 volt resistance, and these were connected to the common terminal. That became the indifferent electrode, always having a zero potential, so that is Wilson's central terminal, right? So ऐसे आपने एक indifferent electrode को generate किया, so that every time when you are picking up the activity, you are only going to pick up the activity of the active, exploring or the unipolar lead. So what is unipolar? It is the lead. How it is generated? It is the active minus indifferent electrode. What is bipolar? Negative and positive terminals. What is unipolar? Active or the exploring electrode minus indifferent electrode. So you have got the various chest leads, V1 to V6. You need to know their positions. V1, 4th intercostal space, right side of the sternum. V2, 4th intercostal space, left side of the sternum. V4, 5th intercostal space, mid-clavicular line towards the left. V3 is between V2 and V4. V5, 5th intercostal space. V6, 5th intercostal space. Left side में दोनों, but V5 is anterior axillary line and V6 is the mid-axillary line. So you can see how beautifully this figure is given, where you can see that the chest leads are being applied when you are recording an ECG. So we've understood bipolar, we've understood unipolar, that is the chest leads. Now let us understand what is augmented. Okay, what do we mean by augmented? So augmented का dictionary meaning क्या है? Augmented का dictionary meaning है magnification. Now when the exploring electrodes of the unipolar lead is placed on the limb, जो अभी हम कर रहे हैं, what we are doing, that when we are taking the exploring electrode of the unipolar lead and we are taking it on the limb. In case of the chest, we were keeping it on the chest. लेकिन अगर हम एक unipolar lead लेते हैं, अगर वो हमारी exploring lead है, उसको अगर हम limb पर connect कर रहे हैं और दूसरा terminal is the indifferent electrode, then we find that the voltage or the recording of that voltage is very small, not good. So in case of V1, V2, it is V1 minus the indifferent electrode. But when you are keeping the exploring electrode on the limbs and you are taking the other as the indifferent electrode, which is the Wilson's terminal, उस समय the recordings are very small. The magnification is not good. So what do? You bring about certain changes in the arrangement so that the magnification can be augmented. So the voltage can be increased or the augmentation can be done. How? By detaching the connection of the particular terminal limb from the central terminal. That means whatever limb you want to augment, उसका connection आप central terminal में से निकाल दोगे, and you will find by doing this you can increase the voltage. How much? By around 50%. That means, see, look into this figure. Now suppose if I want that I have to take that of the when I'm speaking the augmented limb RA, that is AVR, it will become AVR now. So इसका हम क्या करेंगे? We are going to detach this. सिर्फ इसी का टर्मिनल हम डिटैच कर देंगे, राइट बाकी दो टर्मिनल्स हम रहने देंगे, बट जो राइट आर्म का कनेक्शन है वो कनेक्शन हम इसमें से निकाल देंगे विल्सन्स टर्मिनल में से, एंड इट विल बिकम ऑगमेंटेड. सो what is augmented? What was bipolar? Positive, negative. What was unipolar? Exploring electrode minus indifferent electrode. What is augmented? Augmented limbs are recording between one limb. The limb that is considered is going to be positive and the two other limbs which are going to be negative. That means though augmented are unipolar, but their arrangement is such that as if they are bipolar. है ना, हम क्या कर रहे हैं बाइपोलर में पॉजिटिव माइनस नेगेटिव, हम ऑगमेंटेड में क्या कर रहे हैं. सो इट इज द डिफरेंस बिटवीन वन पर्टिकुलर लिम्ब. फॉर एग्जाम्पल इफ आई से AVR, so it is right arm, and here the right arm is active or exploring, therefore it will become the positive terminal, and the remaining two, that is the left arm and the left leg, will become negative or the reference electrode. Similarly AVL, that is left arm, this left arm it is active or exploring, which will become the positive terminal, and the right and the left leg together will become the negative. If I say AVF, that is the left leg or the left foot, it will become the positive terminal, and the remaining two, that is the negative, the right arm and the left arm, will become negative. So augmented is recording between one limb that is positive and the other two limbs which are negative or reference. This also has appeared as a MCQ question in AIMS examination. Now it can be derived mathematically also. What you have to derive, that AVR is 3/2 of VR. This is again MCQ. Now let us consider augmentation. So let us consider AVR, that is the right arm. Now what is just recollect the leads again, AVR, AVL and AVF. What is AVR? Right arm minus the remaining two. ऐसे ही पढ़ा ना हमने, अभी क्या पढ़ा था, right arm and the other two which will become negative. So AVR is VR minus the remaining two, the left leg, the left arm and the left leg. This is derived from the connections because the right electrode has been removed from the central terminal. Didn't I show you the right arm which was removed from the central terminal, right? The voltage of the indifferent electrode. Now this is actually not behaving as indifferent because here the connections have been changed. उसमें कैसे था, तीनों को आपने 5000 ओम से कनेक्ट किया था, इसमें आपने कनेक्शंस को चेंज किया है. That is right arm you have removed from the central terminal. Mind well, while recording ECG, you do not bring about any change in the connections. It is an automated machine. You have to just pull the limb leads and the chest leads. So ऐसा नहीं होगा कि आपको augmentation करना है तो आप wiring करोगे. It is automated. This is, we are understanding that how are we generating augmentation mathematically. Now okay, come back. So this is derived from the connections because the right arm electrode has been removed from the central terminal. So now it is equal to the mean of the voltages of the two electrodes, that is VL plus VF divided by 2. Therefore now AVR, though we say that it is unipolar, actually it is behaving like bipolar. It is unipolar but it is behaving like bipolar because it is having one positive terminal and one negative terminal, and its voltage is the difference of the voltage between the electrodes. And what is this equal to? This is equal to VR minus VL plus VF divided by 2. We've seen this now. What is augmentation? AVR was VR minus the sum of 2, which were the negative terminals. So AVR is VR minus the other two, the mean of the two. What is left? Left arm and left arm and left foot or the left leg. Now we know the law that VL plus VR plus VF is 0, right? Or you can say that VL plus VF is equal to minus VR. तो इसको अगर हम इधर ले लेंगे, सिंपल अलजेब्रा जो हम करते थे 10th में. So AVR now is what? VR minus VR by 2. We've taken this now, okay? We've taken this, so don't get confused. We are just I mean replacing, we are only replacing the simple algebra, we are not creating any confusion. So AVR is equal to VR minus VR by 2. So VR plus VR by 2 comes to 3 by 2 VR, right? So this is how we derive that AVR is augmented as 3 by 2 VR. Remember that augmented limbs are actually unipolar, but they are behaving bipolar, right? So I've put in all my efforts, boys and girls, to teach you that we have got bipolar, which is nothing. One is positive, another is negative. Then we have got unipolar limb leads. Unipolar becomes VR, VL, VF, and the 6 chest leads, which is nothing, which is the exploring or the active electrode minus the indifferent electrode. In case of augmentation, it is the limb, suppose it is right arm, so it is AVR minus the sum of the two, that is the left leg and the left arm. So this is behaving as the positive terminal, this is behaving as the negative terminal. So it is very important to understand the basics at the level of first prof. So this is the ECG gel and how the person is tied with all the ECG machine, ECG procedure, ECG machine. And obviously I will be taking this more in the detail. Today I have basically concentrated what was on the, how do we get into the various ECG leads. So I'll be repeating this again. It is a thermosensitive wax coated paper, and the calibration is done with the speed of the ECG paper is 25 mm per second. So on the x-axis 1 mm will be 0.04 second, and on y-axis 1 mm will be 0.1 millivolt. So this is how the ECG looks like. We will be studying how there are what are the causes of the various waves, intervals and segments. So that is going to be the next part of the lecture. I hope you've understood. I always say you that please make it a happy learning. So please remember to put on your comment, your valuable suggestions, and help us to grow in this channel. Bye-bye and take care. बेटा टीवी लगा